So last video I had discussed about the structure of the thoracic region. Today I am going to talk about the intervertebral disc of the thoracic area. So basically it is somewhat similar with the lumbar area, but it makes only difference with the size and the movement. In the thoracic area, the movement will be very much restricted than comparing with the lumbar area. So the thoracic disc size are thinner in the thoracic area. The ratio of the disc size to the vertebral area is smallest, also smallest in the thoracic area. That is one reason why the movement is getting restricted in the thoracic area. So if you want to know more about the thoracic area movement, it is just because we have our ribs and some internal organs inside our thoracic area like heart, lungs, diaphragm, everything is there. So if our thoracic vertebra moves more frequently or it is more flexible like lumbar area, there are more chances like our internal organs can get damaged. So that is one of the reason why thoracic area is not mobile comparing with the cervical as well as lumbar area. Now the intervertebral discs are also somewhat wedge shaped with the posterior height greater than the anterior height. That is one reason why we are getting the kyphotic posture or what we call as primary curve. Just see here we are having a primary curve like this, which means convex in the posterior part and concave in the anterior part. So if a curve is convex in the posterior part, that is what we call as lordosis. If the disc, if the curve is convex in the posterior part, that is what we call as kyphosis, not lordosis. So this is how we are getting a kyphotic nature, in the sense if it is a wedge like appearance and the spine is like this, which means it will be a wedge like experience where the posterior height will be more than the anterior height. So what happens is, if we are seeing so many discs in the wedge shaped one, then automatically we will be getting a kyphotic curve. So next, the thoracic vertebrae are primarily resistant to the movement and are considered as the primary stabilizer of the mobile segment. That's what I explained before. Our internal organs have to be protected. For that, our ribs is there, and in order to give an enforcement, the thoracic area is not moving much. So the articulation, the interbody joints of the thoracic spine involve the flat vertebral surface that allow all translation to occur, and the intervertebral disc allow for the tipping of the vertebral body, however, is relatively small size, which limits the available range of motion. So now I am going to discuss about the function of the thoracic region. Thoracic region is less flexible and more stable than the cervical region, as I had explained in the last slides. So because of the limitation imposed by the structural elements such as rib cage, spinous process, taut zygapophyseal joint capsule, ligamentum flavum, and dimension of the disc and the vertebral body. For example, see my body. If I want to tilt lumbar, see here it is called as lateral flexion. See, you have to stand anatomical position. If you are going to the lateral flexion, it is a lateral flexion of lumbar spine. So just see here for the thoracic area, or move for the lateral rotation because of the rib structure, as a rib structure won't permit the thoracic area to move further. So each thoracic vertebra which articulated with a set of pairs at the ribs by the way of two joints. So the ribs will be getting articulated with the thoracic area. It is called as costo-transverse joint. This vertebral component of the costo-vertebral joints are demi-facet located on the vertebral body. In the structure, in the last video, we had discussed about the demi-facet structure, which is located in the thoracic body. And the vertebral component of the costo-transverse joints are oval facet on the transverse process. Now we'll discuss about the kinematics. I know kinetics is bit difficult than the kinematics. Kinematics will be really easy for us to understand. So all motions are possible in the thoracic region, but range of flexion extension is extremely limited in the upper thoracic region, that is T1 to T6, because of the rigidity of the rib cage and because of the zygapophyseal facet orientation in the frontal plane, and as well as in order to maintain our stability, in the sense internal organs as I discussed. In the lower part of the thoracic region, the zygapophyseal facet lies closer to the sagittal plane, allowing an increased motion of flexion and extension. So sit and reach test, which means we have to sit straight, then we have to try to touch our toes. For that, I have seen in so many clients, their lumbar, actually our lumbar area had to flex forward, but instead of that, they'll be using more of the thoracic region, which means they'll be arching like this. So if they are arching like that, it is a indication that their lumbar areas range is getting restricted. This is just for your knowledge. And the lateral flexion and rotation are free in the upper thoracic region. So the range of motion in the lateral flexion is always coupled with the some axial rotation. Even though lateral rotation is free, but it won't be that great comparing with the lumbar area. So we have, if you are comparing the lumbar area, the thoracic area movement will be very much restricted. So the amount of the accompanying axial rotation decrease in the lower part of the region because of the change in the orientation of the zygapophyseal facet at T10 or T11. In the upper part of the thoracic region, lateral flexion and the rotation are coupled in the same direction, while rotation in the lower region may be accompanied by the lateral flexion in the opposite direction, which means coupled motion they are explaining. So the direction of the coupled rotation may vary wide among the individual, because it's not like every individual will be following a same pattern. According to the individual, the pattern can be changed. Then now flexion in the thoracic region is limited by the tension in the posterior longitudinal ligament. As I had explained, if the ligaments, role of the ligament is to stabilize the joint either by preventing the movement initially, or it will completely prevent. In the sense, ACL, it is an example for a ligament, anterior cruciate ligament. It is situated in the knee joint. It will prevent the further anterior translation of tibia after a particular moment. So here the posterior longitudinal ligament will be limiting the flexion, and the interspinous ligament and the capsule of the zygapophyseal joints also limit the tension or limit the flexion in the thoracic region. So the extension of the thoracic region will be restricted by the spinous process, lamina, zygapophyseal joint, and the tension in the anterior longitudinal ligament and the zygapophyseal joint capsule and abdominal muscle. Especially almost all the structures in the anterior part will be restricting the movement, that is extension will be restricting by the anterior part structures. So now the lateral flexion, which is restricted by the impact of zygapophyseal facet on the concavity of the lateral flexion curve and limitation imposed by the rib cage. So this I was explaining in the first slide, where when you are taking the lateral rotation, it is not like completely lateral flexion won't be there, but it will be restricted a lot. In a sense, we have to, our body will be having a role to protect almost all our body alignments. Like for example, pain. If you are getting pain, means it is a stimulus which indicates we have to stop further movements. It's an example I am telling. So in that way, if we are going to the further lateral rotation beyond a particular limit, it can damage our internal organs. So it will be restricted by the impact of the zygapophyseal facet on the concavity of the lateral flexion curve and limitation imposed by the rib cage. So this rotation in the thoracic region also is limited by the rib cage. When a thoracic vertebra rotates, the motion is accompanied by the distortion of the associated rib pair. The posterior portion of the ribs on the side to which the vertebral body rotates become more convex as the anterior portion of the rib became flattened. Now, the amount of the rotation that is possible depends on the ability of the ribs to undergo distortion and the amount of motion available in the costovertebral and costotransverse joint. So, as we are progressing with the ages, the costal cartilage ossify and allow less distortion. This results in the reduction with the aging of the amount of rotation available. So, if you are comparing the movements, the thoracic movements will be very much restricted. I am repeatedly telling because we won't be able to, it is of actually it's of further use won't be there if we are taking away the rotation or even movements. So, if you are comparing the lumbar area or cervical area, the thoracic area's movement is very much restricted. I know I am repeatedly telling the same point because I just want you to understand the points clearly. Now, we will discuss about the kinetics. In kinetics, the thoracic area, which is subject to increased compression forces in comparison with the cervical region, because of the greater amount of the body weight that needs to be supported and the region's kyphotic shape. So, because of the kyphotic shape and the body weight, it is subject to increased compression forces than comparing with the cervical region. So, the line of gravity that falls anterior to the thoracic spine, this produces a flexion movement of the thoracic spine that is contracted by the posterior ligament and spinal extensor. For example, in thoracic spine, it will be a kyphotic arch, that is posterior, this is anterior. So, the line of gravity will be falling just anterior to the thoracic spine, which produces a flexion movement on the thoracic spine that is contracted by the posterior ligaments. So, these posterior ligaments and the spinal extensor, these are the spinal extensors and the posterior ligaments have to contract for the opposite action which is produced by the line of gravity. So, if as our body is in a kyphotic shape, the line of gravity will be falling anteriorly to our body. So, the posterior structures like posterior ligaments and the spinal extensors have to counteract in order to compensate the movement. Now, the greatest flexion movement is at the peak of kyphosis as a result of increased movement arm to the line of the gravity. Now, we will discuss about the structure of the lumbar region. As you will be able to see here, in lumbar area, it will be a mild lordotic curve will be there because of the body weight. As I had discussed in the first class, we have a primary curve that is what we call as kyphosis, and we have a secondary curve that is what we call as lordosis. So, the secondary curve occurs when the baby puts a weight on his lumbar or that spine and they started walking. Due to the weight we will be getting, or due to the action of the weight that is produced on the vertebral bodies, we will be getting secondary curves on the cervical area as well as on the lumbar area. So, in lumbar area, the first 4 vertebrae are similar in the structure. The 5th lumbar vertebra has structural adaptation articulation with the sacrum. As I told, sacrum is a fused bone which is fused in nature. So, L5 is attached to the sacrum. The typical lumbar vertebrae, so it have a body. The body of the typical lumbar vertebrae is massive with the transverse diameter that is greater than the anterior posterior diameter and greater than the height. So, because of the massive body structure which is aligned just because our body weight have to be transmitted through the lumbar region. So, the body's height as well as vertebral structure should be strong enough in order to take part of or in order to bear our weight. The size and shape reflects the need to support the great compressive loads caused by the body weight, ground reaction forces and the muscle contraction. So the spinous process, which is broad, thick, and it extends horizontally in its nature. The vertebral foramen is triangular and larger than the thoracic vertebral foramen, but smaller than the cervical vertebral foramen. So when you are comparing, cervical area will be having more mobile joint, then lesser for the thoracic area, then more for the lumbar area. So the fifth lumbar vertebra is a transitional vertebra and it differs from the rest of the vertebra, that is from L1 to L4. L1 to L4 will be having almost similar features, but L5 will be having almost similar feature comparing to the sacrum. And it has a wedge shaped body whose anterior portion is of greater height than the posterior portion. So in the thoracic area, the posterior portion is having height more than the anterior portion. That can be one of the reason why, or that can be the reason why the primary curve is maintained in the thoracic region. But as here the anterior portion is greater height than the posterior portion, so what happens here, we will be getting a mild lordotic curve. So L5 bar L5S1 lumbosacral disc also is a wedge shaped one. The superior discal surface area of L5 is about 5% greater than the areas of the disc at the L3 and L4. So inferior discal surface area of the L5 is smaller than the discal surface area of the other lumbar vertebrae. Also, the spinous process is smaller than the other lumbar spinous process, and transverse processes are larger and directed superiorly and posteriorly. So, the lumbosacral articulation formed by the fifth lumbar vertebra and sacrum, which means L5 and S1 will be combined together in order to form the lumbosacral articulation. The first sacral segment, which is inclined slightly anteriorly and inferiorly, which forms an angle with the horizontal called the lumbosacral angle. This is one of the important part, lumbosacral angle. This can be asked in your examination. In a exam point of view, it had to be thorough. So the first sacral segment, which is inclined slightly anteriorly and inferiorly, which forms an angle with the horizontal, which is called as lumbosacral angle. The size of the angle varies with the position of the pelvis and affect the superimposed lumbar curvature. So an increase in the angle, which will result in an increase in the lordosis of the lumbar curve and will increase in the amount of shearing stress at the lumbosacral joint. Hopefully you will be knowing what I mean by shear force. So just get back to the shear force and just try to find out what I mean by shear force, because it is there in the first chapter of the biomechanics. So as of now, today we are discussing about the thoracic region, intervertebral disc, its function as well as structure of the lumbar area. So in the next class, we will discuss further. Thank you.